Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Oh, this is an article that very timely because the flu season is here, and there's still some people who are not vaccinated. And one of the important reasons to emphasize this is because now's the time to take the vaccines before November, because from November to April is the real flu season. So if you haven't gotten it already, now's the time to start getting it before the end of October. And these are just some data that you're already aware of, but anyway, just to reemphasize that last year, more than 900,000 people were hospitalized due to COVID, and more than 75,000 people died from COVID last year, and that's much less than the year before. And the flu, still, 45,000 people died from the flu. So getting vaccinated is so important. Then RSV, the new vaccine, especially for those of us who are over 60, is very important. And remember, for the flu vaccine, if you're over 65, there's a special dose because if you're over 65, your immune system is waning. And so it's important to let them know that you're over 65 and you get the high potency vaccine. Also took occasion to remind you about shingles and pneumococcal. Shingles is a two-dose vaccine that is important because all of us have had chickenpox when we're young, but when you get older and your immune system wanes, the virus reactivates and gives you the shingles, which gives you intense nerve pain, which is long-lasting and hard to deal with. Then the new pneumonia vaccines that we've discussed before, the newest one was this year actually, and that vaccine usually lasts 5 years. But if you haven't got the new vaccine, you may consider getting it. But if you have been vaccinated within the last 5 years, it may not be necessary. But the new vaccine covers more of the causes of pneumonia than the other one. Also, keep in mind that the purpose for the taking the COVID vaccine is because you have new variations on a theme that are not covered by the old vaccines, and so it's important, even though you receive the old vaccines, to get the new updated vaccines. Any comments or questions about this update? Because you're all well aware of it anyway, but I just wanted to remind you because now's the time.
I have a question. Number one, I got my flu shot yesterday, and I have a friend who's a senior citizen. He got his flu shot in August. Is it effective? Should he get another one? I know the
Well, he shouldn't have gotten it in August.
yeah.
Number one.
Yeah.
He shouldn't have gotten it in August because the vaccine usually lasts about 6 months. So getting it early is a mistake. But whether he should get it again or not, I can't. How old is he?
He's 76.
Oh, did he get the double potent?
He said he did. Yeah.
Oh, okay. Well, I guess no, I wouldn't advise him to get another shot, but I'd advise him against doing that again. The time to get the vaccine is October or late September or October, not August. It's recommended against getting it in August. Why did he get it in August anyway?
They were going on a trip to Canada, someplace, and he wanted to protect himself from everything. He said, I'm gonna get my flu shot. He got it in August, mid-August.
Yeah, well, okay, all right.
Yeah.
I'd let him talk to his primary doctor, but it's a 6 month issue. So if you get in August, the immunity might wane
Yeah.
at the
Okay.
time of the peak of the flu season.
All right. Thank you. I'll let him know.
Okay. Any other comments or questions about this important topic?
Just a comment. Good morning, everyone. Charles and I are scheduled to get our COVID and our flu today at noon. So
Good.
that'll be all three for now. I don't think we're
Mhm.
gonna get any more.
Okay, good. Okay. What
Well,
about your shingles? You got that already and your pneumonia?
No, we just got the RSV a couple of weeks ago, and we're getting these two.
yeah.
Okay.
Ah,
You didn't have pneumonia in the past?
no, never. So
And no shingles, huh?
no.
Mhm.
I had chicken pox late in my I didn't have chicken pox till I was in junior high school. So I'm hoping that shingles will stay away too for a long
Well, you're vulnerable.
time.
Okay, all right. Um, let's go to the next one then. There's no more questions. This is an interesting article about what doctors wish you would do daily, and these are things that we talk about almost every program. First, of course, stay active. Uh, and the more active you are, the better off you are for the most part. And as Darryl often mentions, the importance of aerobic and resistance weightlifting becomes very important together. They are very good for your future. And then, of course, uh, biking, swimming, yoga, those things are good as well. So then challenge your brain, exercise your mind daily with many things, including meditation and mind games. I think probably the one thing that you can do to address the issue of Alzheimer's, in addition to the eating food and exercise, the right foods and exercising, is to challenge your brain with new things and mind games and languages and music and those kinds of things to keep your mind focused. Because while we don't have a treatment for Alzheimer's, perhaps the prevention of Alzheimer's may be the one thing that you can do. The importance of staying social as we talk about the loneliness epidemic that we're dealing with, which is particularly bothersome for seniors and especially men, uh, older men. It's important for them to be involved and you know, of all the people they interviewed who were men, the one that seemed to be the most optimistic was one of the reverends who talked about his relationship with Jesus Christ. The others seemed to have no hope at all, and seemed on their way out because they were very depressed and had nothing to look forward to. Management of stress, of course, is something that becomes even more problematic with age. And what happens as you age, you realize that the things that you considered burdens are really blessings. And the more you have burdens, the more blessed you are, probably, because doing nothing is one of the worst things that can happen to you. Then stay on top of your appointments, see your doctors, get your eye exams, your mammogram, prostate exams, colonoscopies, and other such things so that you can stay in good health. And staying outside in the sun is something you can do if you protect your skin, because skin cancer is one of the commonest things that you can have. But if you cover your skin with sunscreens appropriately, then the vitamin D that you get from that as a consequence is of value. And then, of course, finally, we probably hear from Darryl and others how important it is to eat healthy foods and to fresh fruits and vegetables, foods high in fiber, and eat less meat, more vegetables. Uh, and those are the 7 things that they're recommending that we talk about almost every session that we have. Any comments about this article, which is refreshing? Okay, now let's go to the next one. And this just is a reminder that the new COVID-19 vaccines target the variants that new that aren't in the old COVID vaccines. And so that's the reason why, even though you had the old ones, you need to get the new ones. These variants can cause the need for hospitalization and death. And as we talked about earlier, that 75,000 deaths last year from COVID alone. So we need it. If you hadn't gotten it this year, it's time to get the COVID and the flu vaccine and the RSV. Okay, let's go to the next one.
And I wanted to say too, something was sent out recently in case some of us don't have it. You can get new COVID testing kits, 4 at a time. The other day I had a headache for a couple of days and someone said, "Oh, you had COVID." And I went to take the test, and the ones that I have here expired a couple of years ago, but I don't think that makes a difference. They say they were good for a while. But I think it was last week something went out where you can order new testing kits, which I did, and you can get 4 at a time.
Wonderful. Thank you for that information. Thank you for sharing.
Mm-hmm.
Dr. Callender, do you know whether or not they are still recording on a card your COVID vaccines?
They are not, so you have to ask specifically for them, and you have to make a record yourself. Because I know I have it on mine, but they do not give you a card. So you keep your card and update it as you go.
Record, don't they?
Yeah, but do you know whether the pharmacist keeps a record of
No,
it? No, it's
I don't
no
know.
record. Okay.
No, I think you need to keep a record of it.
Yeah, well, I still have my card, so I'll take it. My pharmacist will probably write it down if I take my card in.
Right, and ask for a certificate of it. That's what I do. I ask for a certificate because I work in the hospital, so I have to show it if I don't get it done by the hospital. So
Okay.
okay, we've
Dr.
talked about.
Callender, I had a
Yes.
question. What is the purpose of having your card, being a card carrying member of the COVID people, the COVID people who have tested? What is the purpose of carrying your card around?
For yourself, so that in case anybody wants to know whether you have COVID, whether you're going to go out of the country, go stay here, or I think it's very good for you, your own purposes, to know exactly what your COVID status is, and also your update status for all your vaccines. While your primary care doctor may know, I think it's important for you as well to be informed and know about your own status.
I thank you. That answers a question because you might have to have it if trying to go out of the country. You might have to show it in order to get your passport.
And get back into. To leave and to enter. Right. Okay, let's go to the next one. And yes, the vaccines work. That's why we're giving the updated vaccines. So this is for men, patients with elevated PSAs. When you have a PSA that's higher than 4, the question is because of low-grade cancer or something else? And so which type of biopsy is thought to be best? And most people feel that the MRI targeted biopsy is the biopsy that is one that is most likely because it identifies where the suspicious lesion is and also allows you to biopsy. And this study did a randomized trial of screening for prostate cancers and identified that one of the things you can do rather than just get a garden variety biopsy of the prostate is to get an MRI directed biopsy so they know exactly where to target, and they also once they get the biopsy they would have a good idea as to whether it is cancer or not and what the extent of the cancer is. So this is what the study identified, that the MRI targeted biopsy was the most useful of the biopsies. And of course, this is just for the men, but just about all men who live to be above 80 will have prostatic hypertrophy or prostatic cancer. So even while getting PSAs is not recommended for all men, I think all black men should get it. But and if it's over 4, then biopsy may be indicated. But
I have a
yeah,
question, Dr.
yeah,
Callender.
yes.
Since you made that statement that all men over 80 are gonna have this sort of a problem, they have preventive measures that they start even when you don't have any lesions or anything. They start you in some kind of a regimen to prevent you from having it. I think that medicine is called tamsulosin.
That's one of them, but that actually is a treatment for it. It's not prevention.
Okay, thank you.
And it's given to people who have benign prostatic hypertrophy, which of course is not cancer, but it causes symptoms of prostatism, which means you get up at night, you have to urinate, and you frequently have to urinate. So, any other questions? Yes, Dr. John Buchanan.
Not a doctor yet. What's the difference between this type of biopsy? I thought a biopsy was where they actually go in and cut out a sample of the prostate.
That's what a biopsy is. The only difference is that you have an MRI directed biopsy so that they identify the suspicious area and they biopsy that specific area. So it's still a biopsy, and they still take a specimen out. It's just that they have a picture of it and they know where to go, and they are more likely to find the cancer if it is a cancer.
And of course, the last question is the expense involved with this. Is it high? Probably.
It's MRI is more expensive than the other X-rays, but it's not prohibitive, and most insurances will pay for it. If you have insurance, it's covered.
Would you have to request?
Well, usually if you have a urologist, yeah, and if your PSA is over 4, then that's something that you and urologist would talk about. and the MRI directed biopsy is what most studies seem to feel is the best type of biopsy.
All right, thank you.
Okay. Well, this is an interesting article, and one of the many articles on loneliness. You may be wondering, what's MDMA? MDMA is the equivalent of what they used to call ecstasy drugs, LSD, those kind of drugs that actually seem to help increase feelings of connection. And what the randomized study demonstrated was that, yes, people who took the MDMA or the LSD actually were helped. And so they think that should be part of the treatment for post-traumatic stress disorder, as well as people who are lonely. And not to say that this takes the place of social connectedness, but it does help those people who are lonely. And since we have so many lonely people, this is food for thought, that there is drug treatment, and MDMA is part of it. Now, this doesn't mean that this replaces the social connectedness, but it does mean that for those who aren't connected, it provides a boost and helps them move towards getting more socially connected. Any comments or questions about this treatment for loneliness?
Yeah, Dr. Callender, I remember when I was in college, there was a lot of experimentation with psychedelics. And,
that's right. Yeah.
But,
and many people thought it wasn't of merit, but now it turns out that it does have some merit when used properly. Yeah. Okay, let's go to the next one. Insomnia is tied to more loneliness, and more sleep is tied to less loneliness. And these are studies that they've done, show that 30% of United States adults reported feelings of loneliness, and 10% reported feeling lonely every day. And one of the things that can help this feeling is to sleep better. Now, of course, some people have insomnia and they have difficulty sleeping, and they may need help in counseling and psychotherapy to help them sleep. But it's clear that people who sleep better are less likely to be lonely. But that's easier said than done. But I think it's food for thought. So if you have insomnia and you're not sleeping well and you're lonely, I think one of the things to do is to get help so that you can sleep and decrease the loneliness. Yeah, the comments about it, insomnia is a common malady, and the recommendation is that you get at least 7 to 9 hours of sleep every night. Many of us don't have a habit of doing that, but it appears that's a habit that should be developed.
My comment is that studies have shown that daylight exposure increases sleep duration and improves sleep quality. So, we had comment on a slide just a few slides earlier that said spend 5 to 30 minutes outside in the sunlight, and that helps you sleep. Along with exercise, definitely helps you sleep. So, a couple of tips if you're prone to insomnia.
Thank you, Darryl. Okay, any other? Of course, this is an article that points out that now, finally, medicine has recognized this as a public health concern. One of the major public health concerns for adults, particularly adults over 65, which is they pointed to an area that is very connected to high suicide rates, particularly in men who are over 65 and who do not have a spouse or social connection. So that recognizing this, now we have to make sure that the physicians talk to our patients and find out if they are lonely, and also if they are, to recommend steps to be taken to address the loneliness. And any comments about any of this? Because this is something that we've been aware of, but it's something that is now becoming a high priority issue for medicine, something that we should have addressed a long time ago, but that we now have the opportunity to address it more so than ever before. Just like doctors haven't asked about your sex life, they rarely have asked if you're lonely either. So this then now is a higher priority item.
Yeah, something else that could help is having a pet. That could help with loneliness. And
That's
you
right.
get your exercise when you have to walk the dog, and you get your sunlight.
Thank you. Good point. Good point. Okay.
A prescription for loneliness could be get married.
If you get the right partner.
Even with the wrong partner.
Don't know about that.
The wrong partner can cause even more loneliness.
The right partner is the key. That's it. You know, of all the decisions you make in life, one of the biggest ones is who you choose as your partner. Right partner is heaven, the wrong partner is the antithesis of heaven. Now that's another item for discussion. How do you choose the right partner? But that's not anything we have anything on today. But that is really the issue, because some people pretend to be who they are, but they aren't who they pretend to be. So choosing the right partner is more than a notion. Any comments or questions about this item that is now, and then one of the things that they're talking about when we talk about choosing the right partner is that there's so many divorces. And so 50% of the people who get married get divorced. And so they get married again and they get divorced again. And so they become even more lonely. So these are items that matter very much.
Okay, one thing I would say about finding the right partner is to be the right partner yourself first. And what I mean by that is that when you love unconditionally, you don't judge. And the most problems that you have is when you start judging your partner or judging yourself. You know, if you're really going to love the easy way. Really love yourself by not beating yourself up. We tend to, as people, beat ourselves up. We're never smart enough, pretty enough, social enough, rich enough. Just be enough for yourself, and be enough for your partner, where you're not judging them either.
Loving unconditionally, selflessly, as you say, seems to be the key.
I remember, everyone doesn't know, but this is my second marriage. And I remember when I announced, or when everyone on my job found out that I was engaged to a particular person who also worked on the same job. Um, I got many people coming up to me saying, "You mean you're marrying him? You get married?" That happened repeatedly. And just as a tidbit, I was married to my first husband. I was with my first husband for 3 years. I didn't get a divorce until it had been 10 years. But I am with the one who they wondered about. We are getting ready to celebrate 35 years in March. So, we're really opposite people, but it works.
Congratulations. And wonderful.
But too, we did find that we're opposite people, but looking into our backgrounds, we found out we had a lot in common. So that helped a
Okay.
lot.
Thank you for sharing. Thank you for sharing.
Mhm.
Any other comments? If not, then now we find that loneliness is also associated with increased stroke risk. This is an article that analyzed thousands of people and found that 12,000 people, and found that not only is it loneliness associated with cardiovascular disease, but specifically stroke. And this is, you can see that 12,000 people were studied and who were over 50 years of age, and they realized that the loneliness led to stroke. So there's so many things that loneliness leads to that are not good, that overcoming it becomes very important. Next slide, please. It's an article. I laugh because my daughter is unhappy with articles that say that you could drink 1 or 2 drinks a day, because she believes, and there's data to support it, that there's nothing good about drinking. Even though the Bible says wine is a little, wine is good for the stomach's sake. And so this article talks about the 10 benefits of quitting alcohol. And you see he has a glimpse of the 4. End of hangovers, improved sleep, better mental health, and healthier skin. But anyway, you sleep better, decreased risk of accidents. We know that some of the accidents are associated with drinking, lower the risk of cancer. This is becoming more and more obvious. It lowers your immune system, particularly if you do binge drinking, but the more you drink, the lower your immune system becomes. It's not good for your heart, and that is actually an alcoholic cardiac atrophy that is associated with drinking, that the weakness of the myocardium is related to alcohol. And then, of course, often if you cut out alcohol, you lose weight, because alcohol is sugar. And improve mental health, less depression, and then your relationships and social life become much more positive. And alcohol affects the brain and the body in so many different ways. It's a depressant, and that's something that we really don't need. This is an article that points out the many ways in which the alcohol is bad for you. So there's not too many organs in your body that are not poorly dealt with by drinking alcohol. So from the head to the toe. And then, of course, increased risk of all of these cancer, heart disease, liver disease, stroke, mental health, and sleeping. We still, though, say that 1 to 2 drinks a day is okay. Although it's clear that the more you drink, the less healthy you become. And this is the general opinion that it's linked to at least 6 types of cancer, and it's considered toxic. But you know, it's interesting that we say that, but it's hard to go to a party without finding alcohol in it and drinking alcohol. And so many people don't even want to go to a party if they don't have alcohol. But these articles still point out the not so wonderful aspects of drinking alcohol.
This may be the reason why I don't have to take any prescription drugs. I've never drank alcohol.
Them drink all these cheeses. We can't read drink all these.
Any other comments? So alcohol and tobacco,
Yeah.
not good for us.
Yeah, that's what I said. I never did either one, so maybe that's why I don't have to take any prescription drugs.
Well, we didn't have a slide on the side effects of Molly, that MDMA. And so instead of drinking, maybe it's better to take Molly, because both of them make you happy. And if you can get the happy without the side effects, then you just go down. I don't know where they sell Molly. I used to buy my weed at a local pool hall when I was a kid. But maybe you go down to the pool hall, you can buy some Molly too.
None of that. None of that.
John Tatum, your hands up.
My father was an exception because he would have a drink every day, all the way up until he was 100 years old. And he had very few prescription drugs. So that's an exception. He took very few prescription drugs, but he had a drink or two on a daily basis.
Interesting.
Drink
Yeah, I would like to say, doesn't the scripture say a little wine for the stomach is good? Didn't Paul say that?
That's what the Bible says. Yeah.
Oh, okay. And then I'm playing for this church and they have real wine. That means I can't take communion.
No, it does not mean that, because the 3 cc's of that you take of communion is not thought to hurt you. If that's all that you drank was 3 cc's of alcohol once a month, that's not going to hurt you.
Oh, but this church is Episcopal. They take it every Sunday. I like them.
Well, those 3 cc's once a week is not going to hurt you.
Oh, okay.
Pearl
I went to a
Lipscomb.
church with real wine, and I just refused to take the communion.
Pearl Lipscomb.
I was
You're
trying
on
to
mute.
figure out
You're on
why.
mute. We can't hear you. We cannot hear you.
Can you hear me?
No, Lipscomb is next, but we can't hear her. Can
Okay.
you let her know
Can
that?
you hear me now?
Yes.
Okay, well, I just wanted to say that years ago, probably 50 or so, the doctor I had at that time had suggested to me that I drink a glass of wine every day. So I don't know, I don't do it now, but I do still drink it occasionally. But I had been drinking a glass of wine pretty much every day for, I know, at least 35 years.
Okay. All right. John Tatum, you had your hand up again?
Yeah, I did. I was trying to figure out why Carol comes home from church drunk, and now I know.
Well, the amount of alcohol in communion is about 3 to 5 cc's, and that's not gonna get you drunk.
However, you know that there's a difference between the tolerance between men and women.
That's correct. Yeah.
And so when she started playing all the wrong chords, I know.
Don't
Okay,
hate
thank you,
John.
John.
She's drinking communion for you.
I have my own at home.
Okay, thank you very much. This is an article that, there's so much going on about GLP-1 drugs, which are glucagon derived drugs, and they're so beneficial for so many things. But there are still side effects to even this drug, which is thought to be the wonder drug of 2024. And this article talks about the nutrients that you need to take if you're on GLP-1s, and they talk about the importance of protein, because the belief is that the GLP-1s result in hypoproteinemia, and so that protein, so that the fat people, they lose protein as well as fat, and so they lose their muscle mass. And so for this reason, they need to take more protein, more fiber. Uh, they sometimes have constipation, and of course, more fiber is well known to decrease the likelihood of constipation. Emphasizing more vegetables and fruits. And these points, see, they mentioned the broccoli, Brussels sprouts, the berries, and beans and legumes. All of these are fiber. And then vitamin B12. Vitamin B12 absorption is delayed with the glucagon medications, and so taking vitamin B12 will help with that, along with calcium and vitamin D. So these the substances that they recommend taking if you are taking the GLP, which is a wonder drug that has helped many people for many things, but it is known that these are areas in which nutrition would be beneficial. Any comments about that? Any of those, on any of these glucagon derivatives?
It mentioned that vegans and vegetarians are prone to have vitamin B12 deficiency unless they supplement with nutritional yeast. And I do that daily. And so I'm not running the vitamin B12 deficiency.
Okay, let's go to the next one then.
Another comment. They were talking about Ozempic face, and
Yes.
I've got a buddy that's taking Ozempic because he's a diabetic,
Right.
and they say Ozempic face is a hollowed out look to your face, an increase in wrinkles on your face that can make you look older, sunken eyes, sagging skin around your jaw and neck, changes in the size of your lips, cheeks, and chin. And yeah, that's real.
Okay, this is an article that is talking about the wonders of the glucagon derivatives, and it's like an endless list of items for which these glucagon derivatives are effective. We know, of course, about the treatment for diabetes and obesity, but we are talking about lowering the risk of opioid overdoses, talking about potential treatment for Alzheimer's and other diseases, so that so I think that we don't really know yet all of the ways in which these glucagon derivatives can be of benefit. Time will tell, though. And also, we aren't either aware of all of the side effects that we have as a consequence, although Darryl mentioned some of them, but I think it's food for thought that as we hear all of the benefits of it, we have to recognize that there are side effects as well. Okay, let's go to the next one. This is an article that says screening for CKD benefit older adults, but it's a flawed article in the sense that they don't talk about what they're screening. Actually, if you screen for protein, it would be of benefit. Tragically, people over 50 are not screened for protein in the urine. And if they did this, it would be a benefit for older adults. They are this is a study done in England, and they don't talk about exactly what they're screening for because it's important to recognize that the earliest manifestation of kidney disease is protein in the urine. And that is something that in the United States is not done in people of color over the age of 50. And it should be, because this is something that once you find you have protein in your urine, you need to start treating it by finding out whether you're hypertensive or whether you have diabetes or whether you're overweight or what's going on, to find out why you have protein in your urine and to see what can be done to eliminate it. And this, to me, is what screening should be done. But this study does not even identify what the type of screening are done, and it doesn't identify the patient population, whether it's people of color or not. And so, so I use this as an opportunity to indicate that if you're over 50, particularly if you're a woman, that you should have urine screen for protein. If it's positive, that should be a sign that you need to do something about it. And what you do about it is to get your weight control, your blood pressure controlled, and also find out why there's protein in the urine, even if you need to get genetic testing. But those are things that should be done for people who are over 50 to make an early diagnosis of early stage. There are 5 stages of kidney disease, stage 1 through 5. Stage 1 through 3 are reversible. Stage 4 and 5 are not. So this is determinable by getting urine protein done. How many of you are over 50 who actually go to the doctor and get your urine tested for protein? Anyway, it's something that is beneficial, that should be part of everybody who's over 50, particularly if they're people of color, because we have 4 times the incidence of hypertension and diabetes than other folks. let's go to the next one. This is an very interesting article that talks about a new approach to treatment of hypertension, where they start off with 3 or 4 antihypertensive medications, but at a much lower dose so that you don't get the side effects that are common to the use of these drugs if you use them ordinarily. And so this is done in London, and whether it will be done in the United States remains to be seen. But this is a new thought of how to do it. The side effects of antihypertensive medications are many, and so there's merit to starting off with lower doses, with the hope that the lower doses do not give you the side effects that you would have from the higher doses. But this has not been proven, but it's a brand new approach to the management of hypertension. Whether it will work in people of color or not has not been ascertained. But it's just to let you know that this is a new way of looking at the treatment of hypertension, recognizing, as we had a paper last week that pointed out, that most people who are treated for hypertension do not have their blood pressure controlled. And so anyway, this is the study that was done, and it did work for these people, and it's thought it's been interesting to see if this can be done in our patient population. Mr. Tatum, you have a question?
Yeah, you know what would be interesting to me if they had blood pressure medicine, which could work specifically for high systolic or high diastolic. You know, if they had medicine that would target those two, and even on the low side, if they were to lower medicine that could target each one differently. You think they'll ever come across that?
Well, I don't know that it matters. I think what matters is that the blood pressure is controlled by whatever medication. They have medications that can do that now. So it's the problem is that people aren't taking the medication and they're not monitoring their blood pressures. That's the biggest problem. We must have about 20 different antihypertensive medications. So that is really the biggest problem, is that people are not taking their medication appropriately, and they're not monitoring their blood pressure. To me, those are the bigger problems than finding the right types of medication. But having a new approach and using 3 or 4 drugs is certainly worth trying, because the concept is that you don't get the side effects, the uncomfortable side effects of any of those drugs. That's the theory. Whether that is what happens is another story. Any comments or questions? Because this is a very important topic, having your blood pressure controlled and monitoring your blood pressure so that you don't have the ravages of uncontrolled high blood pressure, the cardiovascular disease that so many of us have. John Buchanan?
Dr. Callender, I had issues with my original blood pressure medicine. I would get lightheaded and dizzy when I stood up, and my doctor lowered that dose, and I still had it, and then he lowered it some more and put me on another one at the same time at a very low. So I'm taking very small amounts of 2, and it seems to be working. I don't have the vertigo anymore.
And that's the concept that this brings to play that you can have small doses of a couple of medications, which is better than a large dose of one, because it eliminates the side effects, just as happened in your case. Any other comments or anything else you want to share? Next slide, please. Next article, please. This is an interesting article that talks about 90% of the people with cancers have anemia that is undertreated. And most people want to have a hemoglobin of 11 grams per cc. And more often than not, they don't have the hemoglobins at that level. The question is, why not? And sometimes the doctors don't believe that you need to have a hemoglobin that high, because a hemoglobin of 10 is not symptomatic, whereas a hemoglobin of 9 may be. So, so this may be one of the reasons, but certainly erythropoietin therapy and blood transfusions and iron can allow you to have a normal hemoglobin. And this study looks at the consequences of not having a hemoglobin of 11 grams per cc at Vanderbilt, and they did find that this was a problem. And so they are recommending that we eliminate that, and we do things to make sure that we treat them properly so that the hemoglobins are where they ought to be, and that this might improve their care. So, so those who have cancer is one of the things that you can talk to your doctor about, being sure that your hemoglobin and vitamin B12 levels, et cetera, are normalized. And then what they're saying is that a lot of times the doctors don't recognize that this may lead to other complications that are avoidable.
And Dr. Callender, what are some of the results of anemia? Because I you know, as a blood donor, I have to get my hemoglobin levels checked prior to donating, and I know maybe 4 or maybe even 5 times over the time that I've been donating, which is 26 years, I've been denied donating because my iron level was so low. I actually had to go on iron medication to bring my hemoglobin level up. Well, what, you know, I didn't notice any problem, I don't think, but what symptoms can you get from anemia? That's my point.
Well, you can get the same symptoms that you got from your blood pressure being too low. You can become dizzy. You can have no symptoms, but you can also have dizziness, and then they're also talking about the fact that you may also have vitamin B12 deficiencies. But iron deficiency alone will give you a low blood count. But if a low blood count is higher than 10, it's unlikely that you will have symptoms. And even if it's higher than 9, it's unlikely you'll have symptoms. So usually the people who are anemic with symptoms are people who have hemoglobins that are less than 8 grams, which I'm sure you didn't have. You may have been in the 9 or 10-gram area, which is the area in which there are no symptoms, no signs of symptoms. But it's desirable for you to be in the 10-gram or above area for normalcy.
My levels now are like 13, 12, 13, 14 sometimes.
Yeah, that's what it ought to be. Right. But 10 and 11 don't usually give you any symptoms, but they wouldn't allow you to donate. Okay, that's the next one, please. This is for people who have cancer and leukemia, lymphoma, and myeloma. And when you think you're at the end of the line, and I'm sure it has no relevance for anybody on this call, but you may have relatives who have cancer, and being supportive of them and their visits to the doctor, because nowadays, even when the end is near, sometimes radical treatments, including bone marrow transplant and stem cell transplants, may be curative. So even when the end is near, there are treatments that can be beneficial. So in other words, what they're saying is we don't always know that the end is near, and doctors aren't always right when they tell you that your time is limited. They have a good idea, but nowadays with so many different kinds of treatment, with radiation and genetic treatments, we have been able to cure some incurable cancers. So that isn't so much the case with solid tumors, but with the blood cancers that we're learning how to be more efficient at treating them. But still, end of life discussions are important so that you can be prepared by getting everything in order so that should you die, your family is protected. And the question is, I think Janice Stevenson talked about this with her sister in terms of the doctor being brutally honest with poor prognosis. And there's sometimes that backfires, and sometimes that's okay. For example, if you want to let somebody get their will done and get their things in order so that should they die, their families are protected. Sometimes being brutally honest with poor prognosis is something that is desirable. But I think it's very important for you to keep the connection, even when you're saying that it may be less hope or hopeless. That's being connected to the doctor and allowing for hope is something that is important to do. And so this is the concept that this article is trying to share, that whether the prognosis is good, bad, or indifferent, addressing the ways in which you can protect your family should you die, and also have the last days of your life be as comfortable as possible, are important aspects of the doctor and patient relationship. Any comment about this very important article that talks about the many ways of dealing with patients who have terminal illnesses? John Buchanan.
When my mom was like near the end, I'm not going to say it was at the end, but it was near the end. I was sent to interview with palliative nurses, and I'd never even heard of anything like that before. So they have a whole branch at the hospital now to deal with that. And I was definitely caught off guard by it, wondering, why they would do it. But now I definitely understand, because it was a whole new area of life, to get ready for. And we had to make sure that uh, her paperwork was done, her wishes were clear as far as what might happen at the end of her life. But it was definitely, I mean, otherwise I would have gone in totally blind. And so palliative, just that word, I'd never ever heard of it. I'm glad for it though. Thanks.
Thanks for sharing. Any other comments? And this is an area that is expanding as we speak, because preparing your family for the end of life is something that we all should be about, because as we all age, death becomes more likely, and understanding how to deal with death and dying is an important part of living, and knowing how to do your will, how to have people respect your rights when you're near death, and knowing how far you want them to go with you in terms of what treatments you want to have, what treatments you don't want to have. These are all parts of the end of life care that become part of the palliative process. And then, of course, the ultimate is that you want to die with as much dignity and with as little pain as possible. And this palliative aspect of it becomes of the utmost importance. Any other comments about this? Because all of us have to face this with our relatives and friends. And the older we are, the more we lose our friends. No comments. Let's go to the next one then. Now we're dealing so much now with genetic interventions. We're able to go into the gene, to splice it, to cut it, to modify it. And so now we have the ability to even deal with hemophilia, a disease that was thought to be incurable. And now we have ways of cutting out the bleeding with gene treatments. And gene therapy now is becoming something that is not rare. It's something that is around for so many diseases that wasn't around before. And so we have to be aware that gene therapy is here for many things. Hemophilia is just one of the many diseases now for which sickle cell, thalassemia, and many others now are treated with gene therapy. And so we have to be aware that that's a kind of treatment, just as palliative care has become huge, gene treatments are becoming more and more critical. And this is an example of it. Now look at this price. And that's one of the problems with these new treatments. Some of them are just beyond belief. I mean, who can afford that? But yet, that's the kind of thing that some people who are sick are faced with, rather. Fortunately, it's rare, but who could afford to survive? Imagine trying to raise $2.9 million. Anyway, it's just to share the things that are happening now as we talk about gene therapy, we talk about artificial intelligence. These are the things of today and tomorrow that we have to deal with. This is an article that is only to point out, it's interesting with the cardiologist telling us that one of the first things you do when you think you have a heart attack is take an aspirin. Now we have in leukemia, one of the things that may be beneficial is taking an aspirin. So aspirin has its positive sides, even though it does have some downsides as well. But anyway, this article points out that the amount of intracranial bleeding and strokes, septic strokes and deep vein thrombosis, and mortality in leukemia is less when you take aspirin. Let's go to the next one. I wouldn't dwell on this, just to point out that aspirin has its positive sides. Now, when we talk about postpartum depression, there are a number of ways in which you look at the brain, and we do ways and MRIs of the brain that actually look at different parts of the brain function to find out brain imaging, we call it. And the amygdala is part of the brain. And when there's a lot of activity there, and it means that you will have depression. And postpartum depression is tied into that kind of activity. And it's important to diagnose it so that you know how to treat it. It's a dangerous disease because it's associated with women doing after pregnancy, harming their children, harming themselves. And so having this kind of test to find out whether in a pregnant woman, to find out whether they likely to have this depression is a good idea. MRI is not that expensive anymore, and insurance does cover it. So this is something for your children and grandchildren as a test to rule out postpartum depression. Postpartum depression can be a very shocking situation in which the pregnant women detest their children and detest themselves and commit suicide and kill their children or kill themselves. So one of the things that can be done is to do the MRI of the brain to see if they have a amygdala activity, which suggests that you might have to treat them for postpartum depression. And there are some treatments for postpartum depression. Have any of you seen any of your children or grandchildren with postpartum depression?
Not any in my family, but one lady at my church had postpartum depression after she gave birth, and it was pretty bad for a while. She I don't know, just looked like she was in another world. I don't know. It was bad. She did stuff that you wouldn't think a mother would do. But
Right, and this is what happened to one of our doctor's wives. who had postpartum depression, and she did all kinds of things, as you mentioned, that most mothers would never do to their children, including abandoning them.
Yeah.
Yeah.
But what my question really was, and everyone on this panel in the age range as I am, maybe some a little younger, but I don't remember when I was having children, my sister was having children, that those things weren't mentioned. I mean, maybe they went on, but you never heard about them, never saw it, to my knowledge. So
That's
is
the
it
case.
something new?
That's pretty much the case, that in our era it was never discussed,
Oh, okay.
and it's uncommon, but it was never even discussed.
No.
And so when you encountered it, it was shocking because mothers wanted to have children, but to have a mother who didn't want a child and didn't want to be pregnant was never discussed. That didn't mean it didn't occur, but it wasn't discussed.
Okay. Okay.
Any other comment about that? If not, we'll go to the next article. This is progress in many ways because in the past, if you didn't have a sibling donor for many of these sickle cell disease, thalassemia, and even bone marrow, if you needed multiple myeloma, you didn't have an identical match, you couldn't get transplanted. Now we have treatment that allow for gene therapy to be used to treat these maladies. And it's important to realize that just because you don't have a sibling that matches you, that you don't have to give up, and that there are other choices. Bone marrow transplantation, there's gene therapy now for sickle cell disease and for thalassemia, and there will be for other treatments. So that nowadays, patients with sickle cell don't have to go through the agonies of sickle cell disease because there are therapies, including gene therapies, that can help. And this is just to alert us to the fact that there's gene therapies as well as stem cell transplantation that's available for many of these diseases that there weren't before. The only thing is that you want to try to get these diseases treated before they develop severe heart, lung, or kidney disease. And so keeping that in mind, and as you know, sickle cell disease comes in the early on, and many of these people have this disease and these diseases as children, and so that's when they can be treated.
Dr. Callender, how does it actually work? The person with sickle cell gets the stem cells or the gene therapy, and that allows them to receive the transfusion?
No. The gene therapy or the transplant eliminates the sickle cell issue, and so they no longer have the sickling in the blood. So that the hemoglobin S is what causes the problem. And so this hemoglobin S is done away with by the gene therapy or by the bone marrow transplant. So this is the progress that we're making, so that And as you see here, the 2-year survival was 95%, which is come a long way. Okay, let's go to the next one. This is an article about a radiologist, and radiologists, because wear lead-free aprons to protect them from radiation. However, the lead aprons are heavy and they can cause back problems. And this doctor particularly had such a bad back that he couldn't walk. And so he had to have surgery, cervical decompression that saved him from this, but he can no longer wear a lead-free apron. So this makes it difficult for him to proceed with his career as a radiologist. And so is there a way that cath labs can go lead-free? And this is what he was talking about. And for him, wearing lead is no longer an option. So he can either go into another field or do a part of X-ray that does not associate with radioactive beams affecting him. And this is probably only appropriate for the radiologist, but anyway, I thought it was interesting to point out that radiation exposure causes all kinds of problems, not just the lead apron problem. But if you don't wear the lead apron, the exposure causes all kinds of problems. So you have to, if you're a radiologist, you need to wear the lead apron to protect yourself from radiation exposure.
I have a question. Cath labs, is that okay? A couple of weeks ago, we had Quentin Capers on, the cardiologist, and he was talking about doing catheter operations, heart
Yes,
catheter operations. Are those done in the cath labs?
yes, yes, and it's all done with X-ray. So very X-ray. Every aspect of it is involved X-rays because they take X-rays of the coronary vessels and the catheters they use to unblock the vessels. So all of those would be wearing lead aprons.
Okay, but
John
the patient
Tatum?
is not. Patient isn't
Yeah,
wearing a lead apron, so they're getting full exposure to the radiation.
the patient would have the body, but they would get exposure to, yeah. Of course, the difference is the patient would have it one time, whereas the doctor would have it every time they do it. Mr. Tatum?
Yeah, that was my question. The effects that the patient gets from frequent x-rays.
Well, if you're having 100 x-rays, then you're right, it would become a problem. But if you're having infrequent x-rays, it wouldn't be a problem. But yes, if you're having, let's say 100 x-rays, that would become an issue. But if you're having 1 through 5, that's probably not going to be an issue. Betty?
Yes. I remember that when I used to go to the dentist and they would x-ray your mouth, they would put a lead apron over you.
That's correct. They still do.
Yeah, they still do that.
They still do.
Okay.
And it's recommended, yes.
Yeah.
John Buchanan?
Yes, what does CAF stand for? Is that a
I would say in the when they go to the heart lab, they take a catheter and they put it into your blood vessel. And so that's why they call it a cath lab. They put the catheter into your coronary arteries, and they will put ways of bypassing little catheters that bypassed the obstruction to the circulation in the coronary artery. And so that's why they call it a cath lab.
But I mean, they don't have X-rays every time in a cath lab, though.
Yes,
right?
they do.
They have to,
Yes,
so they can see where it's going.
yes, absolutely.
Okay. Okay.
Every time, every single time. Yeah, absolutely. And that's why they call it cath lab. Okay, let's go to the next one. This is an interesting article that exposes something for those who have insulin pumps. And when you go to take off and you go to land, the insulin pump is interfered with. And this is for those people who have insulin pumps to be aware of the fact that upon taking off and upon landing, that the insulin pump is interfered with. And so you can either turn off the pump when you take off, or turn it off, or ignore it when you land. But the point is that insulin pump delivery is impacted by taking off and landing on an airplane. So for those people who have insulin pumps, they should be aware of this and take into consideration what to do at those points of the air flight. This is something that most people aren't aware of, but it's something that is well known in the industry. And this just brings to light. So if you're a diabetic and you're on an insulin pump, on takeoff and on landing, you have a interruption in your insulin pump's activity.
Well, since we're talking about insulin and diabetes, I have a question for a future group session, and that's since diabetes is a common side effect of kidney transplantation, um, and sometimes it can be, diabetes it's post-transplantation, it can be permanent or temporary. We could have a discussion about how kidney patients, transplant patients, can avoid diabetes as a side effect.
Well, remember, diabetes is the leading cause of kidney disease. So many of them have diabetes to start off with. Post-transplant, the use of steroids is the reason why post-transplant patients have diabetes, because of the steroids. And so nowadays we're using less steroids, so you're having less of an issue with post-transplant diabetes. But the steroids is the reason why patients who are not diabetic before transplant, after transplantation, can become diabetic because of the steroid diabetes, which you call it. And so as you lower the steroids, decrease the steroids, then the association with the diabetes becomes less common.
Right. Yeah, I've got a friend who's 9 months post-transplantation. He wasn't diabetic before the transplant, but last week he was diagnosed with diabetes. And so just some general tips on what you can do to avoid diabetes post-transplant if you weren't diabetic before the transplant.
Right, and that issue is how much steroids is he on, because that's what causes for the most part, that's what causes the post-transplant diabetes. I remember that many of my post-transplant patients who were on steroids, once we decreased the dose of the steroids, sometimes it went away and sometimes didn't. But the issue is how much prednisone, how much steroids they are on, and whether if they have a rejection episode, if they have to use high doses of steroids. So that's the usual cause of post-transplant diabetes, is the use of steroids, and lowering the dose of steroids when you can is one of the ways. This is a situation that is more common among blacks than it is among other ethnic groups. Not as common in Latino Hispanics as it is among blacks. And again, it's predominantly related to this dose of steroids, and as you reduce the steroid dose, usually the diabetes is decreased, if not eliminated.
Dr. Callender, I'm one of your patients that this happened to. As a matter of fact, it happened to me three different and separate times.
So the voice of experience speaks. Yeah. So every time you get steroids, then the diabetes returns. When the steroids is stopped, then the diabetes goes away. Or if you have to continue to be on steroid, if you have it at a lower dose, the diabetes is less likely to be the case.
Matter of fact, I'm on possibly one of the lowest doses of steroids, and that's helped me quite a bit.
Are you still diabetic, John?
I am not diabetic right now, no.
Good, good.
They always checking me to see if I do have diabetes because they suspect that I will have it if I don't. And so they check me on a regular basis. But like I said, 3 separate times, and I'm talking about years apart. These episodes, I call them diabetic episodes, they're years apart.
And they're invariably associated with the steroid dose. Okay, let's go to the next one. This is an article, I think we had it before, but we never got a chance to discuss it, I think. But Arthur Kaplan discusses this. One of the things that you have to recognize is that when you have free medical school tuition, here's why that doesn't solve the problem. Because 95% of the people that go to these medical schools are not black. So 95% of them are white. So that the people who may need it the most don't go to those medical schools. And so that's why the free medical school tuition to 1, 2, or 3 schools actually may worsen the problem, because it's only free for those medical schools. And those medical schools, as you analyze who gets into these medical schools, the number of blacks who participated in this becomes lower than it would have been otherwise. And so this is not a way to solve the problem. It's a way to make medical school more available to people who are majorities. That's one of the issues that, and it's interesting because most of this relates to people who have salaries who are less than over $300,000. So those making less than $300,000 will get free tuition. Those who are over that will not get free tuition. But when they look at the majority minority percentage of those people who are actually in these medical schools, the number of minorities are markedly decreased. Number of blacks are markedly decreased. So it's food for thought. This may be the last article. It's 10:30. Any comments about this free tuition thing? We just got Howard University and the historically black medical schools just got was about $1 million for, but that actually was given as not as a to get free medical school, but actually to use to improve the medical schools. And So this is an issue that has come up for a lot of discussion. Any comment about that? Any thoughts you have about the fact that some schools do have free tuition and most schools don't?
That's not just medical schools, that's most schools, aren't they? They don't have that many free
Well, the ones we're talking about are medical schools because
medical.
there's a shortage of doctors.
Yeah.
And so we're just talking about medical schools
Mm.
that they've given these large amounts for. Now, I guess there may be other exceptions, but
Do
most
you
of them,
know which schools they are? Which-
yeah. Johns Hopkins and NYU and Albert Einstein.
oh. Like you said.
Yeah,
Like you said, we don't go to those too often.
right. And we did have Blomberg and one of the other philanthropists gave Howard 1 year and Meharry and Morehouse 1 year free medical school for those people who had salaries at less than 300,000.
Dr. Callender, as a side note, the new president of Howard University is a preacher at Mark's church, New Bethel Baptist Church.
You mean he's speaking at New Bethel Baptist Church? Is that what you mean? He's speaking there, or what? Is that what you're?
No, I'm saying he's a preacher on staff at New Bethel Baptist Church.
Oh, Vincent, Dr.
Yeah.
Vincent.
Yeah.
Oh, okay, all right.
I'm reading that colleges started charging tuition fees in the 1960s due to increased demand for higher education. So this is relatively a recent development within the last 60
It's
years.
not a
where
recent
colleges,
development. It's not a recent development. They've always had tuition. The difference is that the tuition is markedly increased. But they've always had tuition. Way back when I went to medical school in the 50s, there was tuition, but the tuition was much less. But the tuition has become kind of ridiculous as of the 70s, where we're talking about $60,000 a year for medical school. Whereas, for example, when I went to medical school in the 60s, we were talking about maybe $2,000 a year. Now you're talking about $60,000 a year. But they've always required tuition, but it's just that the tuition has become outlandish from 1970s on up.
yeah,
For
I just
example,
read that. I didn't believe it. I didn't believe it either because when I went to school in college in '67, we rioted because they raised tuition from $12 to $15 an hour, a credit hour. Yeah, of course, tuition now, what are the costs? Like several $100s per credit hour at state universities.
Yeah,
So
so
it's
it's
terribly unaffordable now.
the outlandish nature of the tuition is what is the issue. I remember when I went to Hunter College, it was $100 a semester. So they always had to, and that was in the 50s. But $100 a semester, that's nothing compared to nothing now where you pay 60.
Dr. Callender, did you freeze? Dr. Callender froze. Well, while he's getting thawed out, George Washington, the father of our country, stopped his education at age 11 when his daddy died. So he never went to college, where a lot of other rich kids, like George Washington was a rich kid. Typically, the plantation owners sent their children to Oxford University in England, and George Washington didn't get any of that. He just read a lot and was rich. That was his qualifications for being president.
Okay, looks like we're unlocked now, at least. There you go, Doc.
Yeah, yeah. That was interesting. Yeah, yeah, yeah. The wonders of modern technology, huh?
Right
Yeah.
on.
Yeah.
Looks like we have a new visitor of our group.
Hi, Joyce. Good to see you. Who's user?
Like to check in and identify yourself.
Oh, that's Elizabeth. Huh? Oh, no, that's Elizabeth. Hi. But isn't somebody a user? You want to identify yourself? You're welcome. Glad you could join us.
Well, user's been with us since 10 minutes before 9 o'clock. So
Yeah,
uh,
maybe it's a
user's
whole
been with us the whole time and staying with us, even though user won't say anything.
Welcome. Hope you learned a lot and enjoyed what we shared. And you're welcome to come again in the future. Good to have you. Elizabeth, good to see you again. We haven't seen you in a while. So welcome back.
I've bonded with user for his or her steadfastness in staying with us.
Yeah.
Good morning, Dr. Callender. Good morning, everyone.
Hi.
It's
Good to see
always great. It's always great to hear these presentations
you. Okay.
and the input.
Good. Okay. Well, you guys have a great week. October's here already. It's hard to believe. We only got 3 more months for the rest of this year. Time goes so fast. You know, next year, by the way, 1975, we started this group. So next year will be 50 years for us. So we'll be celebrating our 50th anniversary in 2025. So
Are we gonna have a party?
At
that's for
your
us to
house,
decide. That's for us to decide. So
party at Carol and John's.
let's think about it. Let's think about it.
Yeah,
We got time.
Okay.
that's good.
Okay.
Good.
All right. And see you guys next week, God willing.
Yeah, I gotta go get ready for my exam. I mean, for my shot.
Ciao.
I gotta go get ready for my shots today, so I don't have time to chat.
Oh,
Oh,
Yeah, I
And
get
you
mine next
see
week.
everybody though.
and you're still smiling. Okay.
Okay, Betty.
Might as well.
That's because she got the best smile. If you got it, use it.
Gee, thank you, Darryl.
Nobody has a better smile than Betty.
I know. She makes you want to smile.
Smile, Carol. Smile, sister.
Hey, listen, you do know I'm playing at Liberty Sunday.
Oh no. Oh, Women's Day is Sunday?
Yes.
Oh, they changed the day on me. Okay.
Okay.